So when I'm asked about molecular testing for our usually newly diagnosed patients with ovarian cancer or patients I'm seeing for the first time, I'm very interested to see if they've been offered genetic testing, as in do they have an inherited gene from their parents that would put them at an increased risk for developing cancers in their family members, but also helps us provide insight into their cancer to see if we would alter therapies for their cancer. Using those molecular tests, if they were done several years ago, we might try to repeat them as we've expanded those panels to beyond BRCA1 and 2. We're also looking at tumor profiling. There's a lot going on as far as actionable mutations beyond BRCA1 and 2. The whole homologous recombination category of genes, or so-called BRCA-ness or BRCA-like phenomenon. I'd like to now, when I talk about an ovarian cancer patient, include what is their molecular status as I decide and communicate that patient to other providers.
We have, in general, embraced germline testing for all ovarian cancer patients. Our national organizations, including the American Society of Clinical Oncology, the Society of Gynecologic Oncology, and the NCCN guidelines, really outline that testing should be done on patients that are newly diagnosed with ovarian cancer. It's important information for the patient and her family, since we have measures to prevent the development of fallopian tube and ovarian cancers in those individuals that have predisposing germline mutations. Somatic mutation testing in the tumor itself is certainly still under development. I personally use it to make decisions regarding targeted therapies, the identification of certain somatic mutations, particularly in oncogenic pathway, might open up opportunities for treatment with drugs that are still mostly under development, but are important for us to pursue further. There are a number of clinical trials now that need the information in the context of somatic mutations in order to enroll patients. The National Cancer Institute is conducting a trial at this point that is matching tumor mutations with targeted therapies, and in that context, somatic mutation testing is hugely important. We cannot recommend it generally to all patients at this point, so somatic mutation testing still has to be individualized.
In terms of doing germline BRCA testing versus HRD testing, I think there is definitely more data that supports germline testing. We know that it's more predictive and prognostic in terms of what we have studied thus far. So I tend to order germline testing in the upfront setting for all my patients with newly diagnosed ovarian cancer. I think it's also important that patients, if they didn't have germline testing ordered or have their tumors evaluated initially, that to go back and to do that testing makes sense. I think HRD testing can be important in certain groups of patients who are BRCA negative, where if they're somatic positive or HRD positive, may have access to an agent or PARP inhibitor that they didn't otherwise. And again, I think it can be helpful to let the patient know what kind of a clinical response that they may expect with treatment. I like to test in the upfront setting. So if I have a patient that comes in with a newly diagnosed ovarian cancer, I discuss testing with them at that time. If there is a patient that had not previously been tested with recurrent disease, then I address it when available. I tend to order panel testing as opposed to single gene testing, just because I think it gives us more information in general about what drugs a patient may be eligible for. I think the important thing, though, to remember is the more genes that you test for, you're going to find more genes that are deleterious, but you're also going to find more genes that have variations of uncertain significance, where we really don't know what the clinical implication of a positive test might mean.
I'm often asked about whether I order single gene tests for molecular testing or multi-gene panels. And we've really moved to multi-gene panels to provide us the most information and kind of avoid that need for cascade-like testing to where I have to continually wait on additional examples. Now with the way the tests are performed, it makes sense to just order the full panel. When we look at beyond just BRCA1 and 2, the other group of genes that are responsible for inherited risk, and then also convey to us unique sensitivity to PARP inhibitors when we see these category of genes that are responsible for homologous recombination deficiency.